Hello YouTubers, Joe Kersey here on Saturday, August 9th, 2014 at 15:40 in the afternoon Eastern Daylight Time. Now today is a bit of an extended meditation on, or at least, meditation on one illustration about what it means to be a pro. As I have said repeatedly to many people, and especially to my son, a pro is an individual who does what he has to do in order to do what he has to do. Now that sounds like a bit of a tautology, but it's not. There are many times we have to quash some of the otherwise better parts of our nature in order to achieve achieve a goal that is more desirable than maintaining in a pristine state the part of our nature that might be temporarily quashed. Now, the story I'm going to tell you today doesn't necessarily fit into that category, but it does deal with being an aspect of being a pro. And this happened in, it was probably around 1982. When I just started at, I'd been at the hospital in Columbus there for about, after I came back from Fort Wayne, I'd been there about a year and a half. And I got assigned to work with a fella, and I won't tell you his name because he's still alive. But this guy was one of the older thoracic surgeons. And in other episodes, I'll probably tell you a little bit about what he did during his time at Grant, brilliant, brilliant guy. Incredible technician. I'd have let him work on me in a heartbeat. And there aren't too many people I would say that about. He also had some severe personality issues, but a lot of people who are very good at their work do. I can tell you about that a little later, maybe, or perhaps that's just better left unsaid. In any case, I was going to do anesthesia on one of his cases. A case that day, which was going to be a very long case. It was going to be it was going to easily be a 5, 6, 7 hour case. And what it was is a 45-ish-year-old woman had she had what's called a Pancoast tumor, Pancoast, Pancoast. Well, that's the name of the fellow who first described it. And what it is, it's any tumor in the upper chest that involves adjacent structures. The original description involved it arising from the sympathetic nerve chain that went up, along the mediastinum into the neck, and it arose here, and then it ate into adjacent structures. But it had, over time, come to have been applied to any upper chest wall, any tumor in the chest, particularly involving, the lung, that also involved the chest wall, or, like the brachial plexus and structures like that. And she had one of these things, and unusually, in this case, it was deemed to be amenable to resection. Now, she had had some radiation and so forth. Try to shrink these things down a bit. And it was probably due to lung cancer or something. In any case, she had one of these things, big eating cancers, which would only get bigger and more eating her if they'd left it in her. So, time to cut it out. Hot lights and cold steel. So, I got assigned this case, and I went and saw the woman and this, that, and the other. And so I'm in the room. I've got the patient. I have the patient in the room. We're getting her. I'm getting ready to put her to sleep, and now it's interesting. It's the dance of the passive aggressives here, guys. It's the dance of the passive aggressives. See, I had been in the surgeon's lounge with this guy before this case. He didn't say squat to me. Of course, I didn't say squat to him either. And in fact, it was as if we had never been formally introduced. In a way, we didn't even acknowledge each other's presence. So, I go in to do my part. So while I'm in there, I got a message from the surgeon's lounge from this guy. Somebody trots in and gives me a message. Says, "Doctor would like to see you because he's never met you." And I said, "Well, I wouldn't mind seeing him because I've never met him either." And she says, "He wants you to come into the lab." I said, "I'm in the operating room taking care of his patient. He ought to come in here, and then he can meet me." Just ask him if he wants me to put her to sleep, and we can get going. The word came back, "Yeah, go ahead and put her to sleep." So I did, and he duly shows up. Now, he was one of these guys at that time, that traveled. A lot of these surgeons had their own private scrub nurses. They didn't use the people from the hospital. They had their own private sort of traveling scrub nurse. Now he had stopped traveling around a long time ago, but he still had this one scrub nurse. And so we do the case. Now I'm going to tell you right now, this is a big time violent case. There's about a section of the chest wall about. It was actually it was on her right side. It's like for about about a small dinner plate, maybe a bit bigger than a small dinner plate segment of her chest wall was cut out. Those are ribs and everything, along with and connected to. This was all en bloc, as the French say, or in bloc, as the Americans would read it in a journal. All en bloc in one single resected piece, sparing the brachial plexus, but leaving this huge hole. It'd been like a cannonball had hit this woman. So I'm thinking to myself, this is going to be interesting to see how he reconstructs this. Which he did. And they have these this mesh, this Dacron mesh, and he put this mesh in. And admittedly, it's gonna sort of go in and out a bit with your respiratory movements. You try to make it tight, so it's not going to go in and out that much. But there's going to be a little bit. But at least it allows the individual to have effective ventilation after they recover. And it scars in, and the underlying lung adheres to it. And so then he closed with wire. Now I subsequently did a lot of his anesthesia because he grew to like me, and he closed everybody with wire. It's not big wire. It's not like you're taking 14 gauge wire. It's like maybe 22 gauge wire, 24 gauge wire. Sometimes and a lot of chests, particularly the sternums are always closed with wire. Well, almost always when they do that midline incision for open heart. But he would close the abdomens with wire. He'd close everything with wire. And so the case went well. There's always a certain amount. These are very bloody cases, but it wasn't that bloody. It was. Well, this was too. He was one of these guys that sewed the towels into the edge of the wound. Big bloody soaked hole. But I'll tell you, he got this thing, and and I think she did. I think essentially she was almost considered, for all intents and purposes, a cure. She had a little more radiation and did very well afterwards. And she had use of her arm. Didn't nail the brachial plexus. So, excuse me. So at the end of the case, now understand, during the case, he and I had not exchanged a single word, not one word. Nothing. Not even to so much as to acknowledge each other's presence in the room. Well, right away, he had my admiration for that, because I truly admire somebody who is almost as passive aggressive, and maybe even a bit more passive aggressive than I am. Although, I think maybe about a few years later, I ended up being a bit more passive aggressive. So at the end of the case, we're getting ready to transfer her onto the cart and take her down the hall recovery room. And his scrub nurse says to him, "Well, doctor, aren't you going to tell him he did a good job?" And with this answer, this man earned my eternal admiration, no matter how horrible a human being he might have been in other aspects of his life. And there were a couple that he was. He says, "Aren't you going to tell him what a good job he did?" Why should I? He's only doing what he's supposed to do. I thought, all right. That's absolutely right. That's a pro. That is a pro. You do what you're supposed to do. You don't get complimented for doing what you're supposed to do. I loved it. And so herewith, the haiku, I give his name, a haiku number 2. I might run through the entire sequence. I've got about 4 or 5 of them, but today it's haiku number 2. cut off the chest wall. First time I've worked with this guy. And now we have two alternate endings. Alternate ending one. He just did his job. Alternate ending two. I just did my job. Alrighty now. Bye-bye, YouTubers.